tomorrow there is a debate on whether allogeneic transplant should be utilized or not in Philadelphia positive ALL. This, I must say, is one of the hot topics. That's why it became a debate at this Congress, as in other meetings. We've had them before, but people don't exactly know what to do. This is very interesting because in the old days, transplant was the only option for patients with Philadelphia positive ALL. It was in fact a disease or a sub-disease. It's a sub-entity of ALL with a very, very poor prognosis in the old days. So the only chance of cure was indeed, and in fact both for children and adults, if you could go to an allogeneic transplant. Now things have changed because for a number of years we've learned that we can treat patients carrying the BCR-ABL son with tyrosine kinase inhibitors. Now the story started with chronic myeloid leukemia and then moved into Philadelphia positive ALL. And this has been, I would say, quite a revolution in the management because we've been going for the worst condition you could get in hematology, and as I often say, maybe even in medicine, with the Philadelphia positive ALL patients in the past did extremely poorly, very poorly, to an extent that the transplant was the only option if you could get to a transplant, but very often you couldn't. Now with the tyrosine kinase inhibitors, the scenario has changed completely, and patients respond very well to the inhibitors, which means an oral form of treatment. It's a targeted treatment, it's not chemotherapy, targeting the genetic abnormality, which is a hallmark of this disease. And you can put virtually all patients into complete hematological remission. And this can be done either associating a tyrosine kinase inhibitors, first, second, or third generation, with chemotherapy. In the older days, this was with the conventional chemotherapy, which was toxic, so many groups use low-dose chemo with a tyrosine kinase inhibitor, or as we have done through the GMEMA multi-center group in Italy for many years, we've been adopting a different strategy that for all adult patients from 18 years up with no upper age limit, so that means 70, 80, 85, 89-year-old, or treated with one TKI, whether it's imatinib, dasatinib, and steroids in induction without any systemic chemotherapy. There's only prophylaxis of the cerebral nervous system. And that also allows all patients to go into remission. So that we've, let's say, in a way solved the induction. Then you can consolidate with chemotherapy, maybe transplant. That is an open question. What we've learned, so I think that's the first lesson, that you can really put all patients into remission. The second point is, obviously, do you transplant them? Do you give chemo, you don't transplant? So this remains a question. Now, the other lesson we've learned is that it's not enough to put patients into remission, but we have to obtain a state of minimal residual disease negativity. Patients should become MRD negative by molecular biology. That's the only way you can hope to cure. So it's not enough to go into remission. So if you look at the data with the tyrosine kinase inhibitors, you can get a proportion of patients becoming negative, which varies according to the inhibitor. If you add some chemo, it may be higher. We are adding now, but I can't give data yet because we haven't finalized a study, we've added blinatumomab in our frontline protocol for adult Philadelphia positive ALL, where they get a TKI inhibitor, which is dasatinib, followed by blinatumomab. So it's there's no chemotherapy, induction, consolidation. And the hope of that is to obtain a high rate of patients becoming MRD negative. So the question is, will come in a debate tomorrow. Because until yesterday, we would have transplanted all patients. Now, what if the majority become MRD negative? Should we transplant or not? That is a question. Because transplant can cure, but you can die from transplant. Toxicity is high. So the question is, should we? And I will try to underline that probably for many patients will not be necessary for some reason. One, the highest incidence of Philadelphia is in elderly patients. So by definition, the older you are, the less likely you are to be fit for a transplant. Or put it the other way around, side effects increase with age. So if you're older, you get more side effects. Therefore, transplant is obviously a bit more complicated to perform. The other reason is that some patients may be cured. And we have evidence, for instance, if you have a genetic profile, which is a good genetic profile, these patients have a very good prognostic likelihood. So I think what I would say at the end, I haven't finished my presentation yet, but what I would say at the end is that in many patients, probably we can possibly avoid a transplant, an allogeneic transplant. It could be different with an autologous transplant. which is obviously much less toxic because you're using the cells from a patient. But if a patient becomes MRD negative, we can collect his own stem cells and maybe use them. And our data showing that autologous transplant could indeed be an active way of, let's say, consolidating ALL, Philadelphia positive ALL. So that is what I will stress in a debate. Obviously, debate's a bit of a, it's a bit of a game. One thing, the other, we tend to agree, but obviously each of us defends this. But I strongly think of that because in all our trials, frontline trials for ALL, Philadelphia negative, positive, if patients become MRD negative, particularly Philadelphia negative, and don't have high risk factors, we do not transplant. Philadelphia positive, we still have to prove it. But in Philadelphia negative, it's very clear. If you're doing well, completely negative, and good prognostic markers, a transplant is not to be done, at least in protocol. What unfortunately we lack, and this is true, we have no large study, say a randomized study. What we should do, but it's a rare disease. It's a subgroup of a rare disease, so the numbers are small. What we should do is a randomized study. The patients in complete remission, molecular, should you transplant or not? Because, I will make the point, and I guess he would agree, that if you're MRD positive, then you have to go to transplant, if you have residual disease. The question will be for the MRD negative. So we have to increase the rate of patients becoming MRD negative. What could he say? That he could say, for instance, that if you're MRD negative, it's an ideal setting for transplant. Because that's what we say. we tell our fellows in the clinic, to a transplant, it's ideal if you have no evidence of disease. On the other hand, the other side of the coin is, as I mentioned earlier, that you can have severe toxicity from a transplant. So I think the question he would possibly say that for the young patients, probably a transplant would be something advisable, which I couldn't disagree completely. If you have a 20, 30, 40, 45-year-old patient who's responded very well, completely negative, has a good donor, say a family donor, then probably most of us would offer a transplant. What I'm saying is that in a proportion of patients, probably not. And I think this proportion is going to increase because with the new inhibitors and with addition, for instance, of blinatumomab, maybe CAR-T tomorrow, we're probably going to increase the rate of patients becoming MRD negative. So I think the future is going to be with much less transplant. What I think is going to help us further is understanding even more the genetics of the disease, because in the past we thought that Philadelphia positive ALL was one disease. Now we are learning that you can have or not have additional genetic markers, and this is further stratifying prognostically patients. So I think that we'll probably base our decision based on the genetics. My other major issue is that the world is one of my themes that I particularly like, is that unfortunately the world is very heterogeneous. So we've been talking about rather sophisticated approaches, but in most parts of the world this is not doable. So here we're in Central Europe, but it's only Central Europe, North America, Japan, Australia. It's a few parts of the world where you can offer genetic testing and minimum residual disease monitoring. Most places in the world don't do it. We mentioned blinatumomab, although it's experimental, but in the US, FDA has approved blinatumomab to treat MRD positivity in ALL. And in saying this, I would like to underline that EMA unfortunately did not approve it, which is something, let's say, a big issue for us. That in the US they can get it, today they can't. There'll be another appeal at the EMA next month, and I hope something will change. But this is really a missed opportunity for patients that EMA is not allowed to use this monoclonal antibody for minimal residual disease. Having said this, as in most parts of the world, all this is simply not available. So I make it even a simpler plea. I think, this is a disease where all patients can go into remission with an oral pill. I'm not saying they're cured. They can go into remission. As I mentioned quickly earlier, we put into remission an 89-year-old. And luckily, he was tested for his genetics and proved to be Philadelphia positive. He hadn't been tested, as in the old days, he would have died in 2 or 3 months, being 89. He was tested, he was given imatinib, he was in remission for, I can't remember, 1.5 years. Relapsed, he got a second-generation inhibitor. At the end of the day, he turned 90, he turned 91. So he died at 91 and a half, having had for 2.5 years Philadelphia positive ALL. So and he lived a perfect life. He was driving a car. This was in Verona, north of Italy. So I'm saying that you can impact, if around the world they did the testing, you can give a pill and the patient could do well, being cured mostly at home. You don't need, it's not IV. And so the other things are, unfortunately, we're getting always more sophisticated, and the opportunities for the vast part of the world, unfortunately, are going to become more complicated because of cost issues, accessibility to testing, to drugs, to MRD. So these are the big issues we're facing today.